This is a continuation of a discussion that we started really 5 years ago. One of the early events that the Berkley Center organized was with Dr. Schenker. And one of the first subjects that in the Religion and Global Development program of the Berkley Center that we explored was the rather complex relationships between religious institutions and leaders and HIV/AIDS. We were actually building on a number of years of work and observation within the World Bank, but we took a much larger look, and by wonderful chance, Dr. Schenker was here at exactly the time that we were launching the first report that we did. The relationships between HIV/AIDS and male circumcision are one of the many surprises that the HIV/AIDS pandemic has yielded. It was something I don't think anyone expected. I'm not sure that people still have the full logical explanation, though I'm sure that you, as an expert, will be able to bring us up to date. But from the first moment that the association became clear, the rather complex religious linkages came into play. Because so many religious traditions have practices and beliefs around male circumcision, which alternatively could be extraordinarily positive, but which also carried with them some risks that they could be very explosive. We were fortunate, and we're even more fortunate today with 5 more years of experience under his belt, to have Dr. Schenker, who is one of the world's experts on this topic, not only from an intellectual and academic perspective, but also from many years of practice, of trying to explore what it actually means to try to carry out this to carry into practice the insight and the potential that male circumcision offers to save lives and to help us to stem the pandemic. So I want to say how delighted we are to welcome you home. Hope that we'll continue the conversation. Since this is a small group, though actually given that it's spring break, it's remarkable how many people did come. We thought it would be useful if we could go around the table just so that everyone could say who they are and a little bit about what their interest is. And I'll start with Michael Bodakovsky, who I also have to thank for organizing the event and making sure that everybody got together and everybody knew about it. So if we could simply do the quick tour de table and then ask Dr. Schenker to start us off on what I expect to be a lively conversation.
So thank you very much again, Professor Marshall, for the introduction and for allowing the continuation of this dialogue, which I think is important because combining practice and policy development and being a consultant to both UN and other agencies in the field, it's always striking me how the journey that had started approximately 4,000 years ago with Abraham being the first surgeon, circumcising himself at the age of 99, continuing by circumcising his son from Hagar, when Ishmael was 13 years, and then Isaac on the 8th day of birth, to our day today, has been not only a fascinating but a very challenging journey. And what I'll try to take you through this presentation is really not just how far practically kind of counting the numbers, that will be easy, 2 slides and we are done, but to actually share with you so many wonderful, some challenging, but mostly wonderful developments in addressing the need to save lives through male circumcision from HIV infection, which is still a life-taking infection, and definitely one that even if we have the IRTs and other interventions on care and treatment, is an infectious disease, which is a killing disease, which definitely deserves a lot of attention from people in public health, just like myself. So when we look at medical male circumcision, and by the way, it's interesting how the words move. It started by MC, medical circumcision, and then MMC, and now we're talking about VMMC. Who knows where this is still going on further. But anyhow, we are talking about the most common surgery in the world. And if you look on the left side, then you can see that some surprises are there, because in Asia, you see the Philippines and you see South Korea, which are definitely not Jewish nor Muslim, and these two Catholic countries are having universal circumcisions, mostly at neonatal age because of cultural interventions, actually in the two countries relating to this nation, the United States, where the cultural effect of post-Korean wars with Americans at that time being circumcised at a rate of approximately 80, even more percent, has been captured by the South Koreans as a very effective, hygienic, and good tool for life. And we have not known in 1957, 8, and 9 about HIV, of course, at all. The Philippines is another example. Yet we see also other countries like the United States where these numbers are not anymore true, because since 1988, and hopefully next week this will, or in 2 weeks' time, this will change again with the upcoming recommendations revisited of the American Academy of Pediatrics, there has been a deterioration in the rate of intake of male circumcision in the American communities. Australia is still quite high, but just to reiterate the fact that we are talking about something which has been around so many years and has been definitely way beyond the Jewish and the Muslim faith as a practice that has come to play an important role in the hygiene and perhaps also in various areas of health benefits in non-Jewish nor Muslim communities. When we focus on Africa, I think that this is a striking slide actually from the time that we only had observational studies that looked at the correlation between HIV infection and circumcision, and the cutting point of 80% coverage of circumcision in countries, as you can see in the upper side of the slide, where these are countries that almost do not experience a dramatic HIV epidemic and did not experience such an epidemic because of several factors, but one major is perhaps the fact that over 80% of males in these communities have been circumcised. And on the lower scale, we are missing Swaziland with approximately 40% infection rate, or KwaZulu-Natal in South Africa with the same, which represent those countries where less than 20% of men are circumcised at various ages. But until these three clinical, randomized clinical trials conducted in 2005 and published 2005 and 2007, we didn't really have compelling evidence that one can challenge but cannot really argue as long as the environment and the community of researchers, and we are talking about ANSERM from France and NIH in the US, and a wider range of researchers who have looked very thoroughly at the methodologies and the results, and of course this translated into some messages which this busy slides deserves attention towards. So one message comes from the bottom line, and that is actually an up to 60% protective effect of a single variable, which is circumcision. When we are looking at the second important point on this slide, which is the numbers of the participants in those three randomized controlled trials. By the way, Orange Farm is in South Africa, Rakai is in Uganda, and Kisumu in Kenya. We see that this has been a large sample of young men at the ages of 15 to 49 altogether that have been split into the control arm, to the research arm, experiment arm. Those in the experiment arm circumcised, those at the control were not. And of course, the rate of productivity is very impressive, because if we compare, for example, to what convinced governments to follow a policy of introducing anti-cervical cancer vaccination, the efficacy was much less than 30%, needless to say 53 or 60% in moving to a policy which is now overwhelmingly international on the vaccination of young girls at the age of 12 against the papillomavirus. But of course, without policy moving at the global level and at the national level, and without governments endorsing the science, that could have not moved forward as fast as it is moving, though we shall see the numbers and could appreciate ourselves the big gaps yet. So, March 2012, we look back to March 2007. That is when, for the first time, an international agency, that's the World Health Organization, together with UNAIDS being the Secretariat and other UN agencies, which are responsible, let's remember, for giving the normative guidelines that affect our lives. These are the very same organizations that suggest what a regimen is for breastfeeding, how should medical instrumentation look like if they are safe, and how they should not look like in order not to include them in any service delivery, etc., etc., etc. These same organizations are telling us male circumcision is then to be recognized as an additional important intervention to reduce the risk of heterosexually acquired HIV infection in men. And I'm reading this out loud because we are starting at the base point where this is actually the first utilization of male circumcision in a medical health term relating to HIV infection from a normative agency like WHO. It took only 2 months for African ministers of health and governments to look into these recommendations. The UN is only recommending, to endorse them, and to basically tell the donor community, we are ready, we are ripe, we are willing, which is the most important word, if you are providing the necessary funding and the not well-known skills in performing adult male circumcision at high volume. National policies, which you already see around the African continent, primarily relating to medical male circumcision, are touching on key issues. For example, they are listed on the right. What is voluntary medical male circumcision means? What are the targets? The short-term targets, the medium-term, the long-term targets in terms of numbers. Who could provide? A very big issue. Is it only providers? Are there only providers who are surgeons? Very scarce resource in most African countries. Are these medical doctors, or could clinical officers be allowed to perform circumcisions on adults and neonates? Also, the issues of responsibilities. Who take responsibility if something goes wrong? Liability issues, indemnity issues. All this is now covered under the specific policies, and you just see 2 examples, the most recent one from Malawi and the most advanced one from Kenya. But of course, policies are documents and have been approved by the respective bodies in the respective countries, but it takes leadership that could make a difference. And we are seeing here, well, one you know, but the one I'm referring to is the one on the left. That's the king of the Zulu people, 10 million people in South Africa. This is King Goodwill Zwelithini, a Christian, who is leading the Zulu people from a traditional, very important traditional point of leadership. And he, in 2009, was telling his people, if you are belonging to my clan, if you are Zulu, you have to get circumcised. To the Zulu tribe in South Africa, that was not something new, because King Shaka, a predecessor, has been actually stopping circumcision. That has happened about 200 years ago. After that has been the traditional trait of Zulu men for ages. In 2010, King Goodwill Zwelithini, already a year and a half into the programmatic and practical developments in KwaZulu-Natal, the land that he governs as a religious / I would say a cultural leader, definitely not religious, a cultural leader, he was telling that in order to protect him, he has decided that his warriors will go under specific circumcision. And he requested that their circumcision will be performed in clinics that have been opened up by Jews. Well, I don't know of any clinic in anywhere around the world that is catering for adults, except the state of Israel, that is like opened up by Jews. What the king was referring to in his speech at his palace in Nonguma was actually to the initiative that brought to KwaZulu-Natal an effort by a Jerusalem-based international organization called OAC, which I'll talk about in a few minutes, that brought both Muslims and Christians and Jewish expertise to KwaZulu-Natal in initiating the very first clinics that offer adult male circumcision on high volume and high quality in KwaZulu-Natal. But if we look at Malawi, we can see the importance of the religious influence on at one stage, which is the first part that you see mentioned from December 2010, where huge brakes were put on Malawi's national ability to move ahead when already funding was on the ground with adult male circumcision because of particular Christian sentiments suggesting that this is not such an important issue for Malawi, as a country that is definitely seeing a very great AIDS epidemic, because it's against Christianity. And the voices coming from Malawi were political, but related the Christian faith to the reason why circumcision should not become widespread practice for HIV prevention in Malawi. It was a change that has occurred only very recently, that the very same people have now changed their voice, suggesting actually that Malawi should and could go into practicing circumcision for HIV prevention. And one key reason for that is the following statement, which came on the 1st of February 2012 by the Malawi bishops that endorsed publicly circumcision for HIV prevention. Before that has happened, basically Malawi could have not started utilize quite a number of millions of PEPFAR funding for circumcision. And the scaling up plan in Malawi is now fast moving because of a change that has happened due to the influence of religious leadership in that country. Leadership also is relating, of course, to the UN family. And if you're not aware, on the 5th of December, a new framework, a 5-year framework, was announced, a collaboration between UN entities, WHO, UNAIDS, and others, the US government through PEPFAR, Bill and Melinda Gates Foundation, the World Bank, and several others who have come together to suggest that what has been done was not enough, revitalizing, in a sense, the recommendation from 2007 and giving the strength of what has happened on the ground is part and parcel of this 5-year plan. So as I do need to answer how far has male circumcision for HIV prevention in Africa advanced, I think that we can appreciate this table that is trying to suggest, number one, an overall figure of approximately 20 million men to go under the knife, sorry for the language, in the next couple of years in order to make a difference and to avert a sufficient number of cases so that on a community level, that averting of millions of new HIV infections could influence in perhaps reversing, if not halting, the further spread of HIV. This is dramatic. It's dramatic in any way you look at it. I mean, reaching 20 million men under the knife, which means 20 million knives, which means clinics that could cater for such huge efforts. As you can see, the world is not moving fast enough on those targets. The 80% target has been articulated by both epidemiologists and others who are well aware of development work in terms of a kind of a percentage that if one would reach the estimated number of 80% per country of men circumcised, this would have the effect that we all would like to see on the HIV/AIDS epidemic. And as you can see, only very, very few countries, and Kenya is leading those, have already been able to start moving fast enough to reach 30% or 32% of the expected targets. And as you can see, the gradual development from 2008, which was the first year of implementation following the recommendations of WHO and UNAIDS, is not moving fast enough, and we'll talk about some of the reasons. This is a more up-to-date slide. I'm sorry, it's very busy and also maybe not extremely clear, but it's again showing how Kenya is above all others in terms of meeting that target. And I will not go into costs at this presentation, A, because I don't know well the World Bank way of calculating, and second, because I think that we can stay with the fact that the investment only of PEPFAR donors is in the range of hundreds of millions of dollars in Africa, earmarked for medical male circumcision under the current PEPFAR structures. As you can see from this, again, sorry, a bit of a busy table, so we'll take a while to maybe visit it. The key elements for medical male circumcision programs are not just the setting up of clinics to provide the service. We are talking about a complex operation that requires both activities on the demand side, which is demand creation. Not all men know of the research results of the clinical trials to just stand quickly in line and join the others in order to meet the interest to save their own life and those of others from HIV infection. So community mobilization is all about community education and the ability to translate that science into the culture, the attention, and to bring it to the fact that men do need to know about the opportunity to save their lives. I would like to open here a little bit of a kind of an parenthesis and to say that in front of our eyes happened something quite interesting. For the first time in the history of medicine, healthy men are seeking voluntarily engagement with health services. Men usually come to a hospital on a stretcher or when they are really, really sick. And here, men are coming deliberately, healthy, to seek a service in prevention of a dramatic disease. We won't go into all the reasoning why men are coming. Are they only listening to their king or to their bishops, or there are other incentives, which obviously there are. But I make a point that this is an opportunity for those implementers and donors that are involved in medical male circumcision to seize and to see if we cannot build a package that looks at the reproductive and sexual health of men in the context of medical male circumcision and make sense of that opportunity, which is very short, and in that way enhance the health of men in Africa through an effort that is picking on what currently donors like, quote unquote, and that is investing in medical male circumcision. To keep medical male circumcision vertically as a standalone program, to us, to me, doesn't make much sense. So as you can see, there is the issue of community mobilization, but also the issue of training and providing on the supply side, not just the actual clinics or places for the delivery of the service, but also decision-making and training of those who are to supply. This all needs to come under national policies and agreements of the professions, the medical profession and the nursing profession, which are not always stand on the side of the policy makers and are ready to surrender to task sharing or task shifting in a procedure which some would still consider straightforward surgery. The questions that relate to operational research on these few pillars, which we will not go into all of the details, but I will just use a few examples, are quite complicated and are quite important in terms of determining the ability to have a wider coverage of men circumcised. One example has to do with the pre-surgery. Do you provide male circumcision to HIV-infected men? All men, according to all policies that I've seen, must surrender to an HIV test before circumcision. some of them turn positive. Are you turning them away? Because this is an intervention for prevention. Circumcision will not do any good to a man who is infected in terms of not getting him infected. He is already positive. It will also not affect his ability to transmit the virus to his spouse or girlfriend or female partner. Neither it would help if he has a male partner. So we are talking about a situation that is quite important to take decisions on. If you are, number one, requiring HIV testing before circumcision, maybe you drive away so many men who do not want to know their status. That has been the case in Swaziland, for example. If you are looking at those men who are coming, tested, and found positive, and still would like to be circumcised, what kind of a additional service do you offer them when there is a risk, a health risk, to circumcise an HIV positive individual, unless his CD4 counts are above 350, my colleagues in medicine tell me. So this is just one example on the pre-surgery. What about the early post-surgery, which means how do you address the issue of adverse events, some of which you could address only if you see that man 3 times, when he's circumcised, on day 2 after circumcision, and on day 7 after circumcision, and I won't go into the medical reasoning for that. So 3 times a man needs to take a combi or a taxi and get into a service provision area where he is losing hours of work, where he is needing to be using transportation which is not always readily available and expensive, and when he might be out there in a very remote area because that's where the mobile clinic reached him. And now that mobile clinic is away. So who will cater for his follow-up visits on day 2 and day 7? Operational research questions are still unsolved. There are many models, pilots, but still we have a long way ahead in understanding what will make sense of the required protocols, the guidelines of WHO, and how to move about them. So we can ask ourselves, in terms of country response and understanding that there is one team called OAC that I'll explain to you in the next few minutes what it does and who they are, we can ask ourselves, who is giving some technical assistance, advice on this? Could it come from religious groups that are knowing something about circumcision because that's what their sons have been going through when they were up until 13 years old, or up until 8, or exactly on the 8th day after birth? Is it medical people who have gathered experience in urology and who could advise? So OAC, standing for Operation Abraham Collaborative, is definitely not a religious group. It's definitely not coming with religious reasoning for its activities. It is some of the accusations that you find by anti-circumcision groups around the world, including the United States, that try to narrow their perspective so we are convinced of ill motives to do something which, as you can understand from this presentation, seems to be, to me and to many other colleagues, a very worthwhile effort because it saves lives. Yes, it is the medical importance of medical male circumcision and the public health effects that make OAC be partner to that. But let's remember that this intervention doesn't come out of the blues. And obviously, and we should put this on the table, it is religious health assets. The way I'll try to use that frame in a different context than most others sitting in this room may use it, we'll look at. If it was not Abraham circumcising Ishmael and 6 million men in the world, Muslim, circumcised, we would have not known that you can circumcise adults effectively. because Muslims circumcise adolescents, and from adolescents moving to adults, it's not that difficult. If Abraham was not circumcising Isaac on the 8th day after birth, we would have not known actually that there is an importance also to the amount of skin removed, foreskin removed, in order to have an effect on HIV. We would have not known that this procedure is simple, doesn't need anesthesia, could be universally performed even by non-medically trained individuals, like the mohels. They are very skilled, but they are not having a medical license. So out of Islam and out of Judaism, and if we remember that Jesus was Jewish, or circumcised, then we are talking about a life situation that now medical male circumcision is building on experience of thousands of years. So who are these guys called OAC? This is a group which are the world's most experienced medical team in high volume medical male circumcision. They have developed and are implementing a model for international collaboration in the training and the provision of high volume and high quality medical male circumcision. And it's a consortium. It's a consortium that at the moment involves organizations from Israel which have had experience in adult male circumcision that I'll show you in the next slide and two, but also from Senegal. So it's a Jewish-Muslim collaboration, but also an North-South collaboration for the benefit of the lower South, so to say, if we are relating to Senegal in Africa and South Africa and Eastern African countries, which are the priority countries for medical male circumcision, further down. And it is to be appreciated that when we are talking about Israel, we are talking about Israeli Jews, Israeli Muslims, and Israeli Christians who are part of the consortium called OAC. And OAC stands for Operation Abraham Collaborative. What I picked from the history of OAC is the collaboration with Senegal, which started in July of 2009 and developed to actually a joint protocol of using the health assets of Islam in Senegal, a country where doctors and nurses are providing the service of circumcision for children and neonates because of religious reasons, and the Jewish experience from Israel that together now enable the development of a protocol for training and service provision of high volume in Senegal. The WHO and UNAIDS came to Israel, came to Jerusalem in 2006 because there was no other experience that they could relate to in terms of learning how could one perform high volume adult male circumcision on adults. And I don't see any one of you jumping. Adults in Israel? Gentlemen, you've just told us that Israel is a 100% circumcised country. Jews, Muslims, and Christians in Israel circumcise their children, their neonates. So what adults are there to circumcise in Israel? 100,000 adults have been circumcised in Israel post-perestroika. When the Soviet Union collapsed, Jewish people, approximately 1 million, found their destiny in Israel. 500,000 men, more or less, of them 200,000 never circumcised. Persecution of communism, not really feeling Jewish, though being Jewish, etc., different reasons. Coming to the state of Israel, they knocked literally on the doors of the Ministry of Health and the rabbinical institutions and requested circumcision. 100,000 men of these newcomers were receiving the service at a huge volume. Those doctors that were assigned to circumcise them were paid by the piece, not by the hour, which was a great incentive. So they basically built assembly lines to get as many men circumcised as possible. The interesting thing is that not only they got the know-how to do that so fast, but the adverse events have been less than 1.5%, very, very minimal. And if there were any adverse events by themselves, they were very minimal. So this picture you will not see anywhere else in the world but in Israel. A rabbi giving a prayer in the middle of a surgical theater. Because circumcising adults in Israel was for a religious reason. That's the brit. And because the brit was not provided when these individuals were 8 days old, and it was and is allowed by the religion to provide it when you are older, up until 96 years old, which was the oldest person that sought circumcision among those newcomers, said, before I die in the land of Zion, please circumcise me. So he came with his 3 sons and 16 grandsons, and they were all done package deal. So that is to demonstrate the core from where these skills are coming from. And they're not coming only for OAC, but they are coming to the benefit of all those involved. I have to rush a little bit with time, so just to suggest that when we look at the division between adults and infants in Israel, it is clear that while adults could only be circumcised by medical doctors, well-trained and licensed, in a location which is a certified surgical clinic or a hospital, infants in Israel are routinely circumcised in a variety of places which are festivity places. So it's hotels without mentioning any names, and restaurants, and the home of the child, and not only in synagogues. Many people don't know that. One reason why this could occur is that from a medical point of view, you don't need such huge sterility or a sterile, environment to circumcise an adult nor an infant. And the ability from a legal point of view is for lay traditional circumcisers, either mutahers in the Islam community or mohels in the Jewish community, to circumcise infants routinely. So OAC is now deploying those doctors, surgeons. They are very experienced. It's not a huge cadre, but also international surgeons who are willing to go through the training of how to be able to provide high-volume medical male circumcision. They are receiving training not in circumcision, but in working in Africa. So there is a bridging of the gap between coming from a very high-tech country to low-tech environments in the African settings, and the cultural, sociological, and other ways to train individuals who have not been to Africa before in the work in Africa and respect to the African cultures, traditions, etc. They are then performing training for high-volume hands-on, both for adults and neonates, and are contributing to the community education on medical male circumcision and its benefits. On the left is Dr. Douglas Ross, a Roman Catholic, a very important medical doctor with a lot of work in the Catholic circles in KwaZulu-Natal, in Durban, who is explaining to the Minister of Health of KwaZulu-Natal, the person on the right, about why a hospital like St. Mary's Hospital, one of the most veteran hospitals, Christian missionary hospitals in Durban, could have accepted the call from PEPFAR to launch a medical male circumcision program, and how his board was willing quickly to endorse the international recommendations and not to have a problem with an international team based in Jerusalem coming to assist his hospital in initiating their clinics and also in training his teams. And the reason I'm showing you this video from the typical Shembe Christian Zionist church in South Africa is because this has been a very moving experience for Israeli Muslims and Israeli Jews coming on mission for training at St. Mary's Hospital and being invited to the church. And when people heard that we were coming from Jerusalem, you can imagine the festivity and the vibration and the dynamic of the religious efforts to please also the guests, but also themselves in an interreligious event, if you want, that male circumcision could allow. Very quickly, Asipila Clinic is now the gold standard in KwaZulu-Natal. 2 of its teams have been trained. It has been able to perform in 18 months, moving from 0 to over 5,000 circumcisions at a rate of 40 and sometimes 60 per day. And what is interesting is that that clinic allowed itself to host from, again, its Christian belief. The board believed that if they have the opportunity and the ability to utilize PEPFAR funding to contribute further to the community, they have invited on board other hospitals from the public sector who are not missionary hospitals to benefit from the training and the technical expertise offered to St. Mary's, so the propagation of male circumcision will be enhanced in KwaZulu-Natal. And one example of another very known hospital, which is McCord Hospital, actually the first missionary hospital, I think 102 years in South Africa, has been one of the teams that have been trained and has echoed the St. Mary's golden model to implement in their own hospital. The know-how of initiating a clinic and being able to practice high volume and high quality medical male circumcision came from that organization based in Jerusalem, OAC. This is an anecdote, but it also has an important meaning. You see what the young man who is being circumcised does, right? He's reading. And he's been operated on just right that minute. What OAC emphasizes, and I think it's a thumb rule for all those implementers currently in medical male circumcision, and that's another component of how far we have went. It's also to understand that it's not just the removal of the foreskin, but it's the engagement of these men in an educational process that starts from the point or moment that they picked up their cell phone and called a hospital to book themselves for circumcision, and the few weeks or months even that they waited for taking the step and coming to the prescribed day and time. That's where the education for medical male circumcision starts. But what OAC offered is the suggestion that it will also continue during the operation. 18 minutes, captive audience, what else could you wish for in terms of providing good educational materials? We did not, believe me, we didn't choose the name. Okay, Moses' Journey, look at the bottom, it's a USAID, very well structured educational material. Why did they choose Moses and his journey in the context of male circumcision? We have to ask USAID Zambia. But this is definitely a way to introduce the fact that education and clients' education is extremely important. And I'll come to the end by suggesting that if one looks at the St. Mary's Hospital hosting Dr. Westreich, who is an Orthodox religious Jew, who has come with 7,000 adult male circumcisions, so to say, on his hands, to offer the training and the transfer of the skills obtained as part of a multi-national, multi-religious, interreligious mission of Senegalese, Jewish Muslims from Israel to benefit the Christian, mostly, community in KwaZulu-Natal and in other countries. I think that this symbolizes perhaps the importance of the other advancement that we have made in looking at medical male circumcision, and perhaps opening up a whole set of questions that are, to our opinion, extremely important to research and to study, and perhaps the Berkley Center is the right host institution to do that, around this connect between religious assets, the way I've tried to create the context, the practice of circumcision in neonates and in adults, and the development towards better, more perfectionated delivery systems to enhance that. On the left, you can see the joint delegation of OAC with the warriors of the Zulu king that I've told you before, which is a mix of cultures, not only of religions, and how the smiling faces perhaps tell the whole story. I'll end by showing to you the fourth dynasty from Egypt. Drawings, this is a true drawing from the pyramids, demonstrating actually more or less just preceding the days of Abraham, the fact that adult male circumcision was known in Egypt, and the huge gap we still have to overcome between the current very low percentage of circumcisions conducted in priority countries in Africa, well funded, and where the 80% is still ahead of us. Thank you very much.
Thank you very much. Do you want to stay up there?
Sure.
Well, let me start with the first question. You've emphasized a lot the male circumcision, and I'm curious as to whether the issue of female circumcision has come up in your work. And the second thing, I remember when we were talking 5 years ago, the basic idea was that what you should be moving towards is a neonatal circumcision as a general practice, since HIV/AIDS is likely to stay. Is that I didn't hear you talk about that very much.
Thank you very much, Professor Marshall. The answer to the first question is we are trying in every possible way to make a disconnect between female genital mutilation and circumcision. There are no benefits whatsoever, definitely medical and health benefits, to female genital mutilation. There are ample benefits to adult male circumcision and to neonatal male circumcision. And they have been widely reported in the academic press, peer-reviewed journals in recent years. It's up to the point that the WHO has used the term forceps-guided method as one of the methods that is in all of the guidelines. If you'll build an acronym from that, you're in the wrong alley. You would like to avoid yourself from using that, and we have been able to influence the use of the word technique. So it's the forceps-guided technique, which then is FGT rather than FGM, which is a whole difference in terms of your first question. As to the second question, there is no doubt. Neonatal circumcision is the right way to go if one wants to have a sustained effect of circumcision and gain all the benefits possible. The problem with that is a political one, because donors as well as governments would like to see results soon. If we are looking at circumcising stratas of neonates now, the effect on the epidemic and on their own life will only turn true when they are in their sexual age of 12, 13, etc. It's too long for politicians and for donors to wait for results, though everybody understands that that is safer, cheaper, and if one can look at the acceptability studies that have been conducted in ample countries, mothers and fathers are willing to have their sons circumcised. So I call it the short arm and the long arm. So neonatal circumcision would be and is the long arm, but we can't avoid working on the short arm in terms of, getting those men who have already high risk of contracting the virus because they are already sexually active be offered the service voluntarily.
Two quick questions. I guess the first is if you could just talk about the implications of pre-PECs and other new surgical devices or new circumcision devices and what that means for your work in particular, as well as the future of VMMC scale-up. And the second question about, it seems like, as you alluded to, there's two issues going on with with scaling up VMMC. One is a supply issue and one is a demand issue, and you're very clearly working on the supply of, in a very effective manner. And I'm wondering how you see the demand piece going on. Is it when you train teams, are there then people lining up at facilities in order to get the procedure? Is there another piece that also needs to be tackled?
Thank you. Allow me to start with the second question. So, yes, these need to be combined. But in essence, the first thought of those implementers and think tanks, working groups that the UN had convened back in 2007, 6, and 8 was that it's better not to invest first in the creation of a well-developed supply mechanism before sensitization of the communities and creating actually or supporting the demand creation. I think that in most countries this concept had failed, and people don't really like to be offered a service in 1 year time or in 6 months even. There has been definitely an understanding, I think that it came a bit late, but it's not too late, that if you develop services at community level, not shut down one operating room at a hospital in the expense of actually not having trauma surgeries, orthopedic surgeries, cesarean sections, etc., but really moving that procedures room, it's very simple, it's not really a whole operating theater that is required, closer to the community. It is understood that if well-trained teams, a facility that is up and running and that could quickly, cater for high volume is there, then demand will come. It's to be seen, but I think that from our experience in Swaziland and surely in KwaZulu-Natal, that has been the thumb rule. Create well-developed services, well-trained teams, let them not work too hard for the first few months. People will realize and will appear and will come and will be served. So that's on the first question. On the second one, yes, innovation in developing a variety of interventions, including the various devices. There are 2 which are currently on the table awaiting approval of the World Health Organization. Is extremely important. PrePEX will be a game change in the fact that it does not require, it's bloodless, no suturing, no anesthesia, absolutely, and the competitors the same. The only thing that I think I would say needs to be taken also into consideration is on one hand the ability to move to a couple of hundreds of circumcisions a day versus 100, let's say in the more conventional surgery methodologies. And at the same time, what would that do to our lost opportunity in actually catering for development of health systems better on the ground? If you develop a surgical procedures room for medical male circumcision and perhaps also integrate with that other issues of male sexual and reproductive health and family planning, would that not be an investment sustained for the long term as good as getting huge number of numbers sooner circumcised? It's a question. It's not an exclamation mark. I'm still puzzled with the answer. But talking to you today in Washington, on a day that the Israeli president and the Israeli prime minister are meeting the United States President Barack Obama, realizing that the 2 innovations in medical male circumcision on the ground, the PrePEX as a device, OAC as a provider of technical assistance of the supply chain, come from Israel, I believe could make us all very happy.
Thank you. Thank you so much for the interesting discussion this afternoon. It's really good new information for me. My question sort of builds on that last response. I'm interested in what your feeling is and what you predict for the future of funding and support for VMMC. I think it's sort of an interesting time. PEPFAR reauthorization is next year. Nobody knows what that holds. I've seen a lot of predictions of sort of the amounts of money that it would take to get to a tipping point in VMMC, and I wonder if you see that coming along well or not. And I've also heard that the Orange Farm research study might be coming out with some new statistics showing that maybe the protective effect is even more significant over the long term, and that might garnish some additional support.
The Orange Farm definitely will come up with interesting statistics. I would say they're not needed. At the level of 60% efficacy, you don't need to convince, at least not me in public health, and I guess not others in development, that this works well. The other barriers to moving faster and to convincing donors to support are more in the domain of operational issues, as I've tried to allude to. So it's not the science, it's not even anymore the policy, it is really the practice that needs all of the investment to figure out models for rolling out and specifically for scaling up that intervention in those communities. And remembering the 2007 March recommendation, this is an additional intervention. If we'll kind of forget about condoms and HIV testing and behavior change, I wouldn't want to see our world living on those conditions. I don't think that circumcision should replace, but really be an additional effort, an effective one. So I don't see donors, definitely with the discussions of actually new stakeholders, funders coming in soon, actually from the European continent. So it's not anymore going to be just PEPFAR being the key and almost unique source for funding in this area, if one takes into consideration also the enormous investment of the Melinda and Bill Gates Foundation, still a North American entity. It is definitely, if we are smart enough to tailor that intervention and integrate it with other challenges in the healthcare provision and prevention in African countries and soon the Caribbean, I think that we'll see the donors coming along and even remembering that at the moment they are the greatest pushers for this intervention to succeed. It's not that they're just waiting for the groundwork to be happening. In every single country, it's the USAID and the CDC people, I know many of them in person, are really the ones who are pushing for this to be effective and have the widest coverage as possible. So I don't see a problem with funding.
Can I ask one more question? What persuaded the Malawi bishops to get involved? That was a big change.
Yes, absolutely. I don't think that it was just 1 year. I wanted to have some documentation, so I used those media pieces from prescribed dates. But so the honest and candid answer, I don't know. But behind the scene, there has been a lot of advocacy by civil society, by government, and by the donor community in Malawi. You know, when you have a huge amount of money lying unspent that you need to move from 1 year to the other, you want to spend this money effectively. And if there is a barrier, you overcome it.
Hi, I have one question. It's a little bit outside of the context of this presentation, but outside of Africa and Asia, for example, in high prevalence countries that do not have a Christian or a Muslim culture or background, how has male circumcision been welcomed in those contexts?
Right. So you can look at India as a problematic country because of the cultural issues between Indian Muslims and Hindus. If that could have been overcome in some smart way, and if medical circumcision could have been advanced to solve some of those cultural, sect issues, stratas in the Indian community, then you could have seen a tremendous decline in the Hindu population currently suffering from HIV infection rates still high. In China, Cambodia, the other countries of Asia where you see HIV infection, Thailand, quite high, you can see the correlations that I've shown also on the slide from Africa, where actually those countries that are not Muslim, or South Korea or the Philippines, we can name the two of them in Asia, you can see that there is a well-developing and continuous HIV/AIDS epidemic. Acceptance and acceptability is interesting, so that's perhaps something that people may want to further investigate. Papua New Guinea is definitely a place in the world where attention should be given to male circumcision, as this could definitely change the scale of HIV infection in this particular country. Maybe to connect to that is an interesting insight from the Caribbean, which are small countries. The population is small, but this is the second part of the world where the incidence and prevalence of HIV on a regional level is the highest. Haiti with over 2.4% prevalence rates, other countries, Jamaica, Guyana, these are definitely countries prone for the same intervention, and only very few acceptability studies have been made showing more or less the same trend as one could have seen in the publications coming out of Africa, which is relatively high acceptance in countries which have seen less of Judaism or Islam around, but a lot of US influence because of the proximity. And again, the fact that in the United States an overwhelming majority of men have been and are circumcised is a plus for these countries to relate to. Thank you very much for your questions.
Thank you very much. Well, thank you all very much for coming. I think this is it's quite fascinating actually to reflect on where you were 5.5 years ago and to see how much has changed. In some senses, the issues you were preoccupied with then were very different than the ones now. So thank you so much for being with us, and thank to all of you for coming.